This is a presentation on zero separation, neonatal couplet care, and immediate skin-to-skin contact for very preterm infants. I am Stina Klemming. I'm a consultant in neonatology and a NIDCAP trainer. NIDCAP stands for Newborn Individualized Developmental Care and Assessment Program. I've done this presentation together with my colleague, Björn Westrup, senior consultant in neonatology, a NIDCAP professional and researcher at Karolinska University Hospital and the Karolinska Institute. We have no financial disclosures. We have consent from all parents for pictures and films in this presentation. Objectives: to understand the concept of zero separation and couplet care and understand safety issues for infants and mothers. For skin-to-skin contact immediately after birth for preterm infants, being able to plan and organize stabilization and/or transport of a very preterm, moderately preterm or term infant in a skin-to-skin position with the parent. Can we present the biologically expected experiences also for sick or preterm infants? Immediate mother-infant skin-to-skin, suckling, and getting breast milk by mouth. Connection, bonding and attachment, warmth, sensory stimulation, nutrition, microbiome maturation, immune competence, adaptation and stabilization of physiological systems. This is Emilia. She's 13 minutes old and she has initiated many of these issues. This is Benjamin. Benjamin was born vaginally in week 32 plus 1 day. It took him 4 weeks to manage these obstacles. What experiences and what support did he need, and how can we facilitate this? Infant and Family Centered Developmental Care, IFCDC, is a concept where we discuss these issues, the early and immediate skin-to-skin contact, the continuous skin-to-skin contact, and the zero separation between infants and their mothers, newborn infants. IFCDC is founded on the leading-edge work of Barry Breselton and Heidli Zals, the Convention of the Rights of the Child, the Declaration of Infants' Rights from World Association of Infant Mental Health, and the concepts of neurobehavior, neurodevelopment, parent-infant interaction, parental involvement, breastfeeding promotion, environmental adaptation, and systems adaptation. IFCDC is a change of mindset. It needs a change of mindset. It needs system change, and it needs education and training to be implemented. EFCNI, the European Foundation for the Care of Newborn Infants, have stated the European standards for care for newborn health in 11 different areas of care. And Infant and Family Centered Developmental Care is one of these areas. And here we have 10 standards for the care of newborn health. Zero separation and very early and continuous skin-to-skin contact are 2 of these bullet points. To be able to fulfill all these things, we need to understand that change has to be implemented through different systems. The infant, the parent, the family system, the NICU system, the hospital system, and the community system. These systems affect each other in a synactive and dynamic and ever-changing way. We know that we in Sweden are very fortunate in many of those systems. We have parents present from the delivery of the child and throughout the NICU stay. And we already have many of those changes done, but still we have actually a long way to go to being able to fulfill all these different standards at a gold standard level. I often show this picture to remind us who we work for. This premature and sick infant has been resuscitated and then brought back to the mother for a very important moment. We see the parents having eyes only for their infant, and we know that we have done a good job, since the whole picture looks like this. This is Carl. He was born vaginally in week 31, 1,522 grams. He was put immediately skin to skin with his mother and got nasal CPAP. The peripheral line was inserted, and at the age of 30 minutes, he was put to the incubator and transported to the NICU. And this is another way of keeping the family together, to have the incubator still in the delivery room and to stay there. So we continue to do newborn care in the delivery room. NICU staff in the delivery room. We connect equipment to gases in the wall. We have nasogastric tube. We start the enteral feeding. IV line is put and IV fluid if needed, and we keep the infant warm. These are important moments of love. And of course, this family perspective with minimized separation also needs to be there for term infants who were unexpectedly needed neonatal or newborn care. This girl was born term with an APGAR score of 0.47 after a shoulder dystocia. She was intubated at 1 minute and successfully extubated again at 30 minutes after stabilization. She was then taken into the delivery room using this incubator that you see in the background and put skin to skin with her mother for 15 minutes before she was taken to the NICU for thorough observation for asphyxia. She never needed any more extensive treatment, and after some days she was discharged for home. And the parents were very happy about these 15 minutes of skin to skin after the resuscitation. They actually didn't even remember that first half an hour. I would here like to mention a safety issue. I am very reluctant to transport infant with a muscular hypertonia and affected neurology in a skin-to-skin position, because the airway might be compromised if position is not 100% correct. When the baby is then taken to the NICU, skin-to-skin contact will be reevaluated and done with a careful observation. Neonatal couplet care is a concept of care where the dyad of the ill or prematurely born infant and the mother needing medical care of her own are cared for together, from the birth of the baby to its discharge, coupling the care of the baby with the care of the mother. Mothers can be transferred to the NICU only a few hours after giving birth. After vaginal delivery, usually in Karolinska, that is 2 hours. Sometimes they can do an exception and the mother can come along even earlier. Or we stay in the delivery room until these 2 hours have passed, and we can transfer the whole family to the NICU if needed. The organization for neonatal couplet care can be arranged in different ways. And in Stockholm, we have tried mainly 2 different ways. So the current situation we have, the system we use, is where a neonatal nurse care for the infant and midwives from the obstetric department care for the mother. For a period of 10 years, we successfully managed to have an organization where the care of the infant and the mother was done in the same organization with midwives employed in the NICU. Requirements for implementation of couplet care would be to have large family rooms with hospital beds, emergency equipment for mothers, midwives always available on a phone, at least on a phone, or and also preferably in an alarm, emergency alarm system. We need education for nurses and doctors in the NICU for safe care of the mothers, since the mothers are physically in the NICU. And we need an architecture for accessibility. This mother with insulin-dependent diabetes and preeclampsia was cared for in the NICU only a few hours after delivery. The infant is born late preterm with a cesarean section, and the mother has an IV line with an infusion going. There are many challenges with couplet care, neonatal couplet care. You have to be very thorough planning your organization. You need a very a good communication between the different units, communication and cooperation, and you need to solve different logistic challenges. Most mothers are eligible for couplet care, but exceptions could be eclampsia or severe preeclampsia, large bleeding or hemodynamic instability, other reasons for care in the ICU for the mother, contagious disease, and severe psychiatric illness. We have some published and some unpublished evaluations of couplet care. We have seen early breast milk productions with the mothers. We have seen higher incidence of breastfeeding, less reported pain for mothers, lower blood pressure for preeclamptic mothers, easier situation for fathers, of course, not having to divide himself between the baby and the mother, lower stress and anxiety in mothers, shorter length of stay at hospital for the infant, and that was significant for the younger gestational ages and for the period in the intensive care unit compared to the special care unit or special care nursery or level 2 NICU. Parents are more active in the care of their children was one observation that the midwives and the NICU staff could see. And it was easier for staff to see parents as the most important persons in the baby's life from the very start. At Danderyd NICU at Karolinska, we do measure the skin-to-skin time all the time, and for every baby. During periods of measuring for a study, we always have a more accurate number. And during the last measure, like this in a study, that was the SEEN study, the European Collaboration of Research, and you see the reference down there in Acta Pediatrica. We had a mean time of skin-to-skin contact of 8.5 hours a day. Karolinska neonatal department is divided into 3 quite small NICUs. So one level 2 NICU at Danderyd Hospital with 11,000 deliveries per year. and 15 to 18 beds. We have Huddinge with 7,500 deliveries per year. It's a level 3 NICU with 16 to 18 beds. And we have Solna level 4 NICU with 3,500 deliveries per year and 12 to 16 beds. At Karolinska, we did a study on immediate skin-to-skin contact. It was a pilot study for feasibility. And mainly the first outcome was to look at thermal control. But as I said, it was mainly a feasibility study to see how we would practically care for babies in immediate skin-to-skin. And this was published in Acta Pediatrica. We then moved forward, and we were part of a very large study called the IKMC study, or immediate KMC. That study was stopped in advance because of benefit. It included 3,700 infants in Malawi, Tanzania, Nigeria, Ghana, and India. It was babies weighing 1,000 to 1,800 grams, and the outcome was improved survival and reduced morbidity, the main outcome. As part of this study, we did a similar study called IPISTOS, Immediate Parent-Infant Skin-to-Skin Contact, skin-to-skin study in Sweden and Norway, and we are actually still including infants in this study. And you see our trial registration number below if you want to have a more thorough look into the protocol. And the presentation that follows is part of, or it's sort of a workshop for this, how we practically go about to put very preterm infants immediately skin to skin after birth. And first, a very short, a brief presentation of what conventional care looks like in our setting. We have incubators with a transport shuttle. We have CPAPs with humidifier. So we prepare a warm place, often an open incubator with all materials prepared. We have a neopuff, a nasal CPAP, electrodes, and saturation monitor sensor. We weigh all fabrics in advance, the blankets, bed nests, CPAP cap, diaper, etc. We prepare for endotracheal tubes, nasogastric tubes, IV lines, and drugs. If the baby is expected to weigh less than 1,000 grams, we use a plastic wrap. We use nasal CPAP directly if possible, if the baby is not in need of more. Quite often we put an IV line, peripheral line, in an early stage. We unite the family as soon as possible, and here a mother who had a cesarean section, and before she goes to the recovery room, the infant and the mother meet each other. So for immediate skin-to-skin contact with the parent, and if we start with cesarean section scenario, because 50 to 70% of deliveries before 32 gestational weeks in Sweden are C-sections, compared to 17% for term deliveries. In the study, of course, we had an informed consent for parents and staff. We prepare the father with a baby carrier, and you will see pictures of this later on in the presentation. And this is needed before the father or the partner is entering the operating room, since there are special hygiene precautions in that room. We bring equipment and prepare as soon as we know about this delivery. It is very important to have clean equipment going into an operating room. We should try to have a room temperature between 25 and 28 degrees Celsius, and this is a WHO recommendation. We have our equipment prepared with an APGAR clock, preheated humidifier for the CPAP, a monitor, and there are monitors with assessments of temperature, and that can be as a continuous measurement of temperature rectally or with the skin probe. The nasal CPAP and extra long CPAP tubings, the NeoPuff, and a suction device. And we have all this equipment on a mobile equipment on wheels that we call the NICU bridge or the NICUB. Or you can have it as a shuttle and a wheelchair. And here you see the whole Christmas tree of equipment. In the preparation room, in the operating room, this is like a pre-room to the operating room. We prepare the resuscitation table or an open incubator as usual, to be able to move the baby there if needed. We put the heater on maximum to heat the room up. The caregiver here, the aunt, often the father or a partner, is informed and confident, and she is here dressed with the baby carrier under the surgical gown. And a soft blanket for the caregiver's back can be nice. We have long cables and CPAP tubings. There are tubings of 10 feet or 3 meters to reach both the skin-to-skin place and the table. A well-prepared NICU team with an experienced neonatologist and an informed obstetrical team is very important. We have our usual setup with the endotracheal tube, the nasogastric tube, the drugs, and the peripheral line. We connect the CPAP to the gas supply from the wall. And we exchange, if it is a small baby that is expected, we usually exchange the resuscitation table for an incubator. It is a good, if it's not used for the baby, at least it is a good place to keep fabrics warm. Preparation for stabilization follows with a normal procedure of local routines. Nasal CPAP, to monitor vital parameters, to be able to do positive pressure ventilation if needed, and to have temperature control and monitoring. The place is different, but the care is the same. According to ordinary routines, late cord clamping at least 1 minute if the infant is vital, and this is decided by the midwife and the obstetrician doing the cesarean section. Plastic wrap if expected birth weight below 1,000 grams. The midwife brings the infant to the pediatric team. She does a quick assessment that she sees no major anomalies or report anything, of course, to the neonatologist in charge. The midwife is informed to put the infant in a prone position high up on the father's chest, and the midwife reports vital signs. And here you see that the father is informed and prepared well in advance. So we put the baby in a prone tucked position, we cover the baby, and we put in nasal CPAP. This baby is born in week 28 plus 2. He has good vital parameters. The cord was cut after 30 to 45 seconds, and the nasal CPAP was on his nose at 66 seconds of age. The place is different, but the care is the same. You see him here, 1.5 minutes old and 100 seconds old. He then has his electrodes for the EKG on his back as a shape of a large V, a V shape. He is then covered with a merino wool blanket. Since wool keeps you warm even if you are humid, a bit damp, wet. So we put a sensor for pulse oximetry on the right hand, as usual. The neonatologist holds the nasal CPAP and assess good breathing movements with the other hand. The person giving skin-to-skin contact, here the aunt, is asked about if she feels the boy breathing, and she does. An elastic band is put on the cord instead of the hemostatic forceps. Vitamin K injection is given, and a quick assessment of genitals and anus is done. And we measure for the nasogastric tube. And this is done very quickly and swift. The baby is well covered with the wool blanket, and a warm towel or another blanket is put around the baby. We try to keep warm fabrics around. We put a cap on and attach the CPAP to the cap. And the wool blanket is then put up on the head, also covering the cap. So the wool blanket is covering the whole infant, and it is put smooth without folds. And then the baby carrier that this aunt had already before around her is put up over the infant, and of course around the aunt, the skin-to-skin giver. And then we put a special insulating thermal blanket in Flectalon, it's a special material, over the wool blanket and the baby carrier. And this blanket is preheated. The baby is here 8 minutes old, has a regular breathing, a nice color, and good vital signs. The nasogastric tube is put in place, and we start feeding. A peripheral line is put, and sometimes we get a blood glucose test to evaluate if we need a glucose infusion. A safe and secure place in skin-to-skin contact is high up on the caregiver's chest. So we have a nasal CPAP with cap, we have electrodes and pulse oximetry monitoring, we have a temperature monitoring, we have a nasogastric tube, a peripheral line, we have the wool blanket, the baby carrier, the special thermal blanket of Flectalon, and a warm towel on top of that. And then we have a blanket for the adult, the father, to keep him warm and heat him up a little bit extra for him to be able to keep his baby warm. We need to keep some parts of the baby visible for assessment: the face and the mouth, the hand, at least one hand, and the fingers. The baby should be in a sniffing position, on a kissing distance, high up on the parent's chest, sternum to sternum. And in this position, it might be time to meet mom. This is Liv. She was born in gestational age 28 plus 4 days, and she was weighing only 965 grams. And here she's 15 minutes old, meeting her mother who is still in the operating room. The mother has a severe preeclampsia, almost going into eclampsia, and she needed care in the ICU for the first 24 hours after delivery. So for vaginal delivery, it is more challenging. It needs more communication and collaboration with the obstetrical team, or between the obstetrical team and the NICU team. It is very important that we do not disturb and interfere with the delivery process. We need this close collaboration with the midwife and the obstetrician, and mother's safety always comes first. We need to have an informed consent from parents and staff, since this was done in a study. We need the baby carrier on a father partner. The mother has to be prepared also for skin-to-skin contact. So primarily the mother, but we also prepare the father or partner. There might be a need for extra connections for gas supply from the wall, since the mother might need her gases or need the gases for her anesthesia. Yeah, for the gases, for anesthesia. The equipment has to be prepared and put in place well in advance, and then we leave the room. We re-enter the room on a signal from the midwife, timely with parturition. We have warm fabrics, and everything is in peace and quiet, not to disturb the delivery. So here we see our mobile equipment, well-prepared team, and we plan every step. The father has a baby carrier and maybe a cap, like his little baby. We enter the room in the last minute of parturition, and then we bring our warm fabrics. This was Benjamin again, and he was born in week 32 plus 1 day vaginally. He was put immediately skin to skin with his mother, and he was in continuous skin to skin with his mother for the first 7 hours. He was not taken from his mother's skin or chest during the first 7 hours. And after that, he was in skin to skin position with his father. So here we see him at 25 minutes, 60 minutes, and 7 hours, still with his mother. He got a nasal CPAP, a warm wool blanket, a sensor, and electrodes monitoring pulse, and after 25 to 30 minutes, a nasogastric tube was put in place, still on his mother. The first meal of 7 milliliters of milk was given. His mother expressed a small amount of colostrum, which Benjamin got in his mouth. And in 2 hours, a peripheral line was put and a glucose infusion started. Benjamin was transferred to the NICU, still in skin-to-skin contact with his mom. This was a little boy born in Stavanger, Norway, where we also include babies for this study. Twins, very challenging and extra rewarding. Many people can be really crowded, so we need to be even more prepared and even more careful about not interrupting and interfering with anything during the delivery. We need extra equipment, 2 of everything. It's a delicate procedure when vaginal delivery of twins. So we really need to take precautions not to disturb the obstetrical team. Twin 1 was immediately put skin to skin with the father after the cord was cut. And the neonatal team number 1 cares for twin 1 with nasal CPAP, monitoring, peripheral lines, and NG tube. Twin 2 stayed in immediate skin-to-skin contact with the mother. Neonatal team 2 cares for twin 2 with nasal CPAP, monitoring, peripheral lines, and NG tube. And these twin boys were born in week 31 and 5 days. And there's a lot of equipment in the delivery room. "45 minutes after delivery, the mother started to express milk, and she expressed during 30 minutes. She got 10 milliliters of colostrum for each of her babies. That was given orally and in the NG tube because it was so much. After 2 hours, the father got both of his little sons put on his chest, prepared for the transfer to the neonatal department, the NICU. The unexpected has to be expected. There are infants in need of more. This was a C-section in gestational age 30 and 1 day, and the girl was weighing 988 grams. She was put immediate skin to skin with the father. She had insufficient breathing and a low tone. We tried to help her with careful stimulation, and we put the Neopuff to start positive pressure ventilation still in the skin-to-skin contact place with the father. But she was then, that didn't help, or she deteriorated before we even started, and she was moved to resuscitation table, or it's actually an open incubator, as you see, for further stabilization with positive pressure ventilation with the Neopuff. We prepared for intubation, but that was never needed. This is a boy born in week 29. He has a low tone. He is trying to breathe and trying to scream a little bit, but he was flaccid and became bradycardic. He got a few puffs with the Neopuff in the skin-to-skin position. The cord was intact, but as we later found out, the placenta had was already delivered because it was a ablatio of the placenta. At 1 minute and 34 seconds, the boy was brought to the resuscitation table. He got positive pressure ventilation with a Neopuff and intubation with surfactant delivery. He responded very well to this, and at 20 minutes of age, he was extubated to nasal CPAP. He was then brought to a skin-to-skin position with his father in a secure place, in the secure position with the baby carrier, the wool blanket, and the thermal blanket. And at 30 minutes of age, he was then stable with his father and on his way in to meet the mother. We do not transfer babies in a skin-to-skin position if they are intubated, not routinely at least. We do have, of course, skin-to-skin contact for incubated infants in the unit. We have not transferred a newly delivered baby that was intubated in a skin-to-skin position. yet at least. If central lines are needed, we move the infant to the incubator or the table and insert the lines and do the X-ray. After that, we try to, as soon as possible, to move the baby back to a skin-to-skin position, either in a holding position, supine or a little bit to the side, in a bed nest in the arms of the parent, or in a lateral decubitus position in skin-to-skin with the parent. And that is what you see on the right side here. And you can see the small catheter is in place in all of these babies. Always, the position of the baby should be supported and tucked, with the flexed legs, support for feet, shoulders in, arms flexed, and hands together close to the mouth.
Continue skin-to-skin contact, even if technology is needed. The staff will make sure that the technology is fixed well to the baby. When the baby is in KMC, all tubes and wires are taped to the parent's skin. This means they can feel the pressure of pulling out before it pulls out of the baby. If the baby is being moved from an incubator, tape all of the tubes and wires together.
This film and other small clips of films were part of the IKMC study. And I will show you the reference and the link to the film in one of the last slides. This baby girl was born in week 31 and 3 days, weighing 1,700 grams. She was put immediately skin to skin with the mother for 20 minutes. But then the mother was bleeding heavily, and the girl was then moved to the father, because we always have to take safety precautions for the mother. So to ensure the safety of the mother and not to obstruct the obstetrical staff, the infant was moved to the father. The bleeding slowed down, and the mother could stay for yet 20 more minutes in the delivery room before she was rolled off to the operating room for suturing, and the girl and the father was transferred to the NICU. We secure all the cords and tubings with masking tape to the father. And before leaving for the NICU, we need to switch the gases from the wall to the bottles on the mobile equipment to be movable. And then all is set for transfer to the NICU. This is Elvin, 20 minutes old, with his aunt, and you saw him before. And you can notice the snow outside. So of course we are very thorough in measuring that the baby has a good temperature. This is Liv, 24 minutes old, on her way to the neonatal unit, in a secure, safe place with her father. And you can have different equipment, as you see. This is Stavanger, Norway, where they have arranged the mobile equipment with a small hospital bed from the Children's Hospital. So it's a junior hospital bed. The mother who had a cesarean section, so the father has been in the NICU with his daughter for some hours, and now the mother has arrived after recovering from her cesarean section, and then the baby is moved to the mother instead in a skin-to-skin position.
Lying down all the time with your tiny baby on your chest is difficult, as you as mother have to watch your baby all the time. But you also need to sleep and walk around. So we will show you how to make this easier. We tie the baby onto mother's chest in a KMC special shirt. This KMC shirt can be used for the first time before moving a baby on mother or father from the birthplace to the nursery. It also helps you to do continuous KMC all day and night, as the shirt will keep him safe even when you are sleeping. It is important that your baby's skin is against your skin, so take off your bra and other shirts. The KMC shirt comes with a non-stretch white piece of material. We fold the long side of this, and it is tied very tightly across your baby's chest and back of neck. It is under his ear and above your breasts, just under your armpits. His head is slightly up in sniffing position and to the side to keep the baby's airway open. Your baby's hands must be bent up near his mouth so he can comfort himself or suck his hand like he did inside you. Your baby's head should be close enough to kiss and on your chest bone, not low down between your breasts. Baby's legs should be curled up together next to your stomach as if he is sitting. The white tie is to keep his airway open and safe, so needs to be tight. Babies breathe with their stomachs. This sounds strange, but for the lungs to fill with air, the stomach or abdomen needs space to move and not be squashed. The KMC shirt can then be put on and the two triangular sides tied in tight under the baby's bottom. Make sure his feet do not stick out. You should feel your baby tight on you. Many mothers say it feels as if her baby was still inside. This way, the warmth of the mother's skin always keeps her baby warm, with the baby's airway protected.
This was again from the IKMC film that we used for educating staff. This is Benjamin again, and he is here in the neonatal unit in a continuous skin-to-skin with his parents. The parents are taking turns sitting KMC or skin-to-skin contact with him and sleeping, eating, etc. This boy, Benjamin, he did not use his bed for the first days. The metabolic screening blood test was done in skin-to-skin contact. Phototherapy was done in skin-to-skin contact. And during the first 7 days of life, Benjamin spent 8 hours in total in his bed. The rest of the time was in a skin-to-skin, continuous skin-to-skin position with his parents.
Twins are more likely to be born prematurely and may be small for their gestational age. Twins should also do skin-to-skin contact, either having father and mother each having a baby on their chest, helped by other family members. Alternatively, one parent can have both small babies on their chest and the parents can take turns. It is important that both twins have their airways protected at the same time with the white tie and are able to breathe well. Otherwise, everything is the same as described above. The mother will, however, need support when feeding both of her babies at once. If she finds it easier, she can feed one twin at a time. Preterm babies may change color because they have times of very slow heart rate called bradycardia, or even stopping breathing sometimes. We call this an apnea. Keep checking on your baby. You might even feel this happening through the contact of your skin. If this happens, you as mother or father may be told to quickly move your baby to see if movement or standing up will get the baby breathing again. Call a nurse quickly to help you. Firm and gentle stroking may be enough to get breathing started. If the baby is very unstable, he can still be held in skin-to-skin contact, but should not be tied on in case the staff need to quickly give him extra oxygen or other support.
And it's the same as in the newborn setting, that the care is the same, it's just the place that is different. So most things we can actually do in the skin-to-skin position. Here's Benjamin again. Now he's 4 weeks old, and he's now feeding from the breast and from the bottle, and he's discharged. Feeding is not only feeding, it is the beginning of relating, as we see here. And with positive early experiences of eating, the babies build global neural networks that support development and future eating skills across the time period of eating with reflexive motor patterns. Here we see twins having continuous skin-to-skin with their mother, latching onto the breast sometimes, and having these very positive early experiences of eating.
When your baby starts to wake up, loosen the 2 flaps of the shirt just slightly, undo the white tie, and let your baby slide down inside the KMC shirt so that his head is near the nipple. When your baby is awake, he should not be tied to your chest, but be spending this time feeding. It may take time for the mother of a preterm to produce breast milk for her baby. Your nursing staff will provide alternatives. Whenever the baby is at your breast, try to express some breast milk to get his food supply going. You can express the milk by hand or with the pump if available.
And I would like to highlight the importance of making parents feel safe, supported, and calm, encouraging them to sleep and eat healthy, and maybe taking a walk sometime. I also think it is a good idea to encourage the parents to involve their closest family members or friends to help them in their situation. We encourage siblings to spend time in the unit.
This big brother was also born preterm. He is now a healthy 18-month-old boy. Preterm babies do grow, so it is important to keep up your hope.
And the video clips you saw in the presentation were from the training video of the IKMC study. And they were filmed at Stavanger University Hospital, Karolinska University Hospital, and Mowbray Maternity Hospital. It was produced for the IKMC study by Nils Bergman, Jill Bergman, Björn Westrup, Agnes Linnér, and myself. And this is my last slide. So a special thanks to all the families and the staff in the neonatal departments at Karolinska, at Stavanger University Hospital, and Mowbray Maternity Hospital in South Africa. And all the people in the Epistas and IKMC study team. Bill and Melinda Gates Foundation, Lärdau Foundation, Baby Björn Company, and the Department of Maternal, Newborn, Child and Adolescent Health at the WHO. And here are 2 slides with references on this subject. Thank you.